This year at CHC 2016, there was a special symposium on complement-mediated hematology. We had Dr. Eileen Weitz join us from USC to give us a perspective and share her expertise, specifically relating to paroxysmal nocturnal hemoglobinuria and the thrombotic microangiopathies, or TMAs. We now live in an era where we can therapeutically manipulate complement, and this has led to more interest in the last few years of these topics. Eculizumab was the first complement inhibitor to come on the scene and is still the only one available, but there are many more now in various stages of development and some in clinical trials already. Paroxysmal nocturnal hemoglobinuria, or PNH, is a very rare disease, and it can present in various ways. Many of these are nonspecific and indolent, at least at the start. Patients can present with anemias, cytopenias, hemolysis, hemoglobinuria, and thrombosis, as well as marrow failure, and these can be nonspecific and, of course, may be due to more common causes. For that reason, it's hard sometimes to actually think about testing for it. And we know that that has actually an impact on patient care and time to diagnosis. Some patients will wait several years and sometimes even beyond a decade from the start of their symptoms to actually a formalized diagnosis and initiation of therapy. The atypical hemolytic uremic syndrome, TTP, and other secondary TMAs. This is also an area of significant diagnostic challenge right now. They can look all very similar, if not exactly the same, and can be clinically indistinguishable at the outset. The atypical hemolytic uremic syndrome is caused, for the most part, by alternate complement pathway dysfunction. TTP, on the other hand, is caused primarily due to ADAMTS-TS13 deficiency or dysfunction, and secondary TMAs can be caused by a long list of various things. And it is important for us to be able to delineate these. The last few decades has given us a lot of insight into the underlying pathophysiology, and this has led to an ability to more targetedly treat these patients. We have complement inhibitor therapy again for aHUS. We have plasma exchange and anti-CD20 therapy for TTP, and even more recently we have recombinant ADAMTS-TS13, which is being trialed in congenital disease. So I think sessions like this one today are very important for raising consciousness and getting these ultra-rare diagnoses back on our differential. Especially in the era now where we have targeted treatments, it is much more important. First of all, we have to think of the diagnosis because, of course, if you don't think of it, you won't look for it.